But part of what makes IR a lot of fun is pretty much every organ system, most places from the neck down.
Mhm.
Although at some places, IR is involved in brain work and neurovascular work, but certainly everywhere from every organ system from the neck down, we work in.
Very cool. I mean, I hope you guys aren't showing them like the 12 gauge needle before it goes into them.
Right, exactly. No, no, we make sure that an
Like,
old trick I learned from a mentor is don't let the patient see the needle. It's a little scarier than it is.
I'm just gonna start us off. Okay. All right. Welcome to the Rithik Sangani podcast. If you guys didn't guess, my name is Rithik. And my first guest today, he is a board certified interventional radiologist right here in Pittsburgh. He did his medical school at the Cleveland Clinic at Case Western University. He did his residency at UPMC, and he completed his fellowship at Yale New Haven Hospital. You know, practices at UPMC Presbyterian and UPMC Shadyside. And last but certainly not least, he is the director and founder of UPMC's 3D printing program. Please welcome to the podcast, Dr. Anish Ghodadra. Did I miss anything?
Hey, no, good afternoon, Ritik. Thank you for that warm and friendly introduction. Excited to be here.
Yeah, of course. No, thank you for making time to do this. Thanks for being the guinea pig. I really appreciate it.
No, I'm
Uh,
honored to be the inaugural guest here.
yes, sir. Yes, sir. We can jump right into this. So I remember when I was shadowing you, I think there was like the first time we touched upon your background just a bit. So from what I understand, you didn't have like a traditional like path to medicine. Like I don't think you did your 4 years with undergrad strictly and then straight went in. I think you had some time between then. And then your
I did.
background also wasn't purely like your regular biology degree either. So could you talk about that?
Yeah, absolutely. I think I had a bit of a kind of circuitous path to where I am today. So I started off actually doing biomedical engineering at Georgia Tech, and ironically swore I would never go into medicine, and took a job as a device engineer at a startup in Atlanta making spine devices. We were actually trying to make an artificial intravertebral disc. And from there, I went on to medical school, and even my medical school was a little non-traditional. So the Cleveland Clinic's program, it's pretty unique. If I could put a plug in for that, it's a 5-year program where you do a
Okay.
year of research that's kind of baked in. The goal of the program is to create physician scientists, and the approach they take to medical training is actually pretty different too. It's a lot of problem-based learning, peer-to-peer education, and shies away from traditional testing and ranking and those sorts of things. And from there, it was on to residency and fellowship and beyond.
That's really interesting. So take me through it for a little bit. So did you have like a specific moment in your path? Like I think you said was it junior year you just had this like epiphany, like, hey, like medicine. Like
Yeah.
was there a specific moment?
Well, I think it was a couple things. One, I think kind of when I first started thinking about it was my junior year when so my dad had actually worked for a large biotech conglomerate and had been there 20 plus years,
Oh wow.
kind of given his heart and soul to this company and kind of climbed the ranks. And in the midst of some of the economic changes at that time, they basically shut down his department and laid him off. And I remember thinking, wow, if someone can pour their heart and soul into a company, work hard, had advanced degrees, and in a blink of an eye, kind of you can get laid off, and you're scrambling and searching for a new job. That's not something I think is right, and something that I want to necessarily have to face. And the one thing that's true about medicine is it's always easy to find a job, I think, in medicine. And so that was something that did cross my mind. But I thought, what, engineering is still something I enjoy, and let me let me see what that feels like. And so I stuck with the initial startup job out of college, and while I enjoyed the work, it was a lot of creativity, a lot of kind of tinkering at the lab desk, and kind of meeting a lot of different folks and wearing a lot of different hats, being at a startup. I found at the end of the day, I was sitting at a cubicle in front of a computer monitor, and it was too far from patients, too far from people, and kind of didn't realize how much I missed that and wanted that to be part of my career. And that's ultimately what inspired the switch.
That's interesting you say that. I had a similar experience. This was actually during high school. So my dad worked in pharmaceuticals for like 20 plus years. So like he was very, he knew like the healthcare system, the medical background. He had actually a nurse thinking he was a doctor at one point, just how much he knew versus like a regular average person. Like, oh no, you really know your stuff. And he's like,
Yeah.
well. I sold to you guys at one point, but um, that well, he liked that office setting. Like I remember, I sat in this at cubicle and I was like, this is an anathema to my existence. I do not want to be. I do not want to be here for the rest of
Sure.
my life. I can't see myself doing this. I need to talk to people.
Yeah. Yeah. Well, there's lots of jobs that kind of get you out of the cubicle into the field. There's very few jobs that let you, help people in the way that you do and really be able to be there for patients and for people at some of the most vulnerable points in life and really make an impact. And that's ultimately, we'll talk more about this, I'm sure, but ultimately how I ended up in interventional radiology is, well, people classically may not think of that as a field that lets you impact patients as directly as maybe some of the other specialties. It's something that I found that we can make profound impacts on patient lives and kind of their treatment journeys as they go through.
Absolutely. So when you went to apply for medical school, you're going through that process. I'm actually curious, were you ever worried that like your non-traditional background might, because I'm sure a lot of non-trads have this worry, whether it's like a rational fear in some cases or it's an irrational fear. Do you think, did you ever feel like, "Ah, man, I took all this time off of college and, like they might be looking for, or like, I should have done like a post-bac program or something. Like, was that ever like a concern of yours?
Yeah, anytime you deviate from what people tell you is the norm, you always kind of worry. And I think 10, 20 years ago, it was pretty unusual to be a non-traditional student. Whenever people thought of a non-traditional student, they thought of somebody who was looking for a second career, or, was a lot older, or there was some reason, something wrong with their application or something wrong with them that led them to take that non-traditional path. But I was lucky enough, Cleveland Clinic and their program really actually embraced the non-traditional applicant. And a good chunk of my class actually was pretty non-traditional.
Okay.
Everything from working, one guy, a couple guys worked as PhDs before medical school. One guy owned his own construction company and was a
Oh,
rodeo
wow.
clown. And it quite the varied backgrounds, and they embraced that. And what I've noticed over the last 10, 15 years or so is that more and more non-traditional students have made their way through the medical school application process, and you see that consequently in the radiology residency, in IR residency application process. And what was maybe once viewed as kind of an eyebrow raising thing, or why did this guy take this weird route,
Mhm.
or gal, we're now looking at as a strength. I'm biased, of course,
Of
but I
course.
think,
But
I do feel that maybe if your first job where you get a paycheck full time is as a resident, that's quite the culture shock, right? If you think about it, if you go straight through, the first time you actually have a job where you're working full time, that's what you do. I mean, there's lots of folks who work and go to school and juggle that, but having a full time job where that's all you do is residency. And so if you take a non-traditional route and actually have some life experience outside of college, I think there are no absolutes, but it leads to a maturity and a perspective you might not otherwise have. And I think programs recognize that.
yeah, absolutely. I think I'll say this for myself. Like I did before my current job, I did basically 2 years worth of research experience at Hillman Cancer Center, and I matured. I matured more and learned more in like 2 years in the workforce than I did 4 years in college. It's crazy.
Yeah, absolutely. When you are responsible to something like that, when you're not, up until that point, you're chasing grades, you're, moving from test to test, project to project, but having the experience, kind of the daily grind, and really has a way of kind of, like you said, maturing folks and giving you a perspective that's hard to get in any other way.
So that's awesome. So kind of like moving through your story. So like you're in medical school. So you're going through like your first 2 years are didactic and like then the next year are clinical. So in your first 2 years, did you have an idea of what you wanted to do?
Yeah, it's funny. I came into medical school thinking, well, I used to design spine devices, so I'm going to be a spine surgeon. That's what I want to do.
Okay.
I like biomechanics. I like bones. I'm gonna be an orthopedic surgeon. I'm gonna do spine surgery. It's what I'm gonna do.
I think you
Uh,
need to have like your bench press max needs to be 225 pounds to get into orthopedic surgery. And I think your daily protein intake needs to be like at least, if not above your body weight or something, like gram per pound of body weight or something.
Absolutely. As the old joke goes. And you know what? I took that seriously. I hit the gym 4 days a week. I tried to put on muscle. I tried to get my board score to 250, my bench max at 250. And obviously all respect for those guys. What I found as I went through my training was, I liked the OR, but I didn't love the OR. The way that a couple of my colleagues, a couple of my classmates, they lived for the OR, and any free moment they got, they would sneak off to an ortho OR. And as much as I enjoyed the joints and bones and that kind of thing, I found myself also being interested in the rest of physiology, pathophysiology, and wanting to look beyond just a joint. And so um, I found that wasn't what I thought I was going to be headed towards. It really ultimately wasn't what I headed towards. And it's actually kind of funny. Of my class, there were about eight of us who were in our first year said, okay, we're going to do ortho. And of
Okay.
that eight, only two of us ended up actually going into
Oh
ortho.
wow.
And so everyone kind of went into different directions because when you're first starting out, you don't know what you don't know.
Hmm.
And that's what I would encourage folks is it's okay to have a sense of what you like,
Yeah.
but I would go into your med school kind of being a bit open-minded. And it's one thing to like something conceptually, and it's another to enjoy the practice of medicine in that field. I'm an engineer. I love the idea of the heart as a pump and the physiology and mechanics of cardiac function and all things related to that. But I didn't enjoy cardiology, the practice of treating hypertension and treating arrhythmias it just wasn't for me, even though I enjoyed the pathophysiology and physiology of that system. Which again, if I can put in a plug, is that one of the advantages of IR is you get to touch each of the organ systems, so you get to experience a little bit of that without necessarily being inundated with it. And But yeah, keeping that open mind as you go through training, I think is going to be valuable. And the other piece of advice I would give myself as a first or second year med student is any opportunity you get to shadow in, especially one of the specialties that you may not be exposed to throughout your maybe third year med school. So radiation oncology, PM&R, IR. These are all specialties, ENT, that are amazing, and but we don't get exposure to until maybe your fourth year of med school, and by then you may have already decided what you're going to do. So the more exposure you can get to some of these lesser known fields that are not necessarily presented to students early on, I think you may be surprised what you find out.
Absolutely. And I mean, I'm very fortunate to have shadowed you. Actually, funny enough, I got the connection from my younger brother. He was like, "You should shadow this guy. He's 3D printing." I was like, "Oh, thanks, Mel. Thanks for the hookup." Um, but yeah, I didn't even know. Like, I knew like somewhat of interventional radiology, but like it wasn't until like I started shouting like, "Oh, wait, so you guys do more than just sit in a dark room and like read screens of X-rays?"
Yeah, it is. I think IR is a bit of a hidden gem that in the last about starting about 6 years ago, it actually became its own residency that you match into straight out of med school.
Oh wow.
And when that switch happened, I think is when we started kind of stepping out into the limelight a little bit more and being more visible. Uh, when I went through, it was still a fellowship off of diagnostic radiology, and I really had no concept of what IR did until I was a second year resident. I remember as an intern, we would consult IR for IVC filters and tunnel lines and that kind of thing, but I had no sense of the scale and scope of what IR does and just how much fun it is.
Has the field expanded since you were a resident?
It has, that's been the part of what drew me to IR is that we are on the bleeding edge of what medicine can do.
Oh, okay.
And, a good chunk of what I do today, these procedures didn't exist when I was a resident or even a fellow. And every day there's something new. And, it's part of what makes it exciting. Treating areas that I never thought I'd be able to treat, and learning about new things, new pathologies, new tools, learning new skill sets. That's the part of it that never gets old.
Absolutely. There's so many questions to ask you, but going back, let's rewind a little bit. So when you found out, was there a moment again, like kind of like how you figured out that medicine was more for you and not the corporate American life wasn't for you, was medicine was more the way to go? Was there a moment where you found about interventional radiology? Because I think we had talked about how you did radiology and you were like, this is great, but I'm not talking to anybody. I'm not getting that patient interaction that I want.
Yeah, so I think you hit on something important. So, when I all through med school, I was like I said, I was thinking orthopedics and spine clinic and spine surgery didn't quite interest me as I thought it would. So I kind of started thinking about orthopedic surgery in general. But again, like I said, I liked the ORs, but didn't love them. And I stumbled across, I did a radiology elective and stumbled across the musculoskeletal radiologists. And I'll vividly remember sitting in a reading room at the Cleveland Clinic with two radiology residents. And both of them, I told them, I'm thinking about ortho, but I don't know. And both of them were in the same boat. They had thought about orthopedic surgery. One actually was an orthopedic surgery resident and actually switched residencies. And they said, okay, what you want to do with musculoskeletal radiology, you get exposed to that same world, all of biomechanics and joints and everything that relates to that. But the lifestyle's a little bit better. You get to work with all these cool imaging modalities. And we work with all the ortho guys pretty closely. And so it's kind of the best of all worlds. And so I said, okay, musculoskeletal radiology, that's where I'm going to go. I'll get my ortho fix that way. And everyone seems to be super laid back and seems to be having a good time. And they all seem really, really good. So that's what I'll do. And fast forward a little bit, I get to radiology residency. And, I remember a couple months into my first year, I kind of remember just kind of almost waking up one day and kind of looking around saying, I left engineering because I didn't want to sit in a cubicle working in front of a computer. I wanted to work with people. And looking around the reading room, I found myself sitting in front of a computer, not directly working with people. And it's okay, well, I had a bit of a crisis and said, well, did I choose the wrong specialty? Should I have done something else? Maybe I should have done surgery after all. And at that time, we didn't do interventional radiology as a rotation until second year. So my first exposure to something interventional in the radiology world was actually my neuroradiology elective, where I spent a couple weeks doing lumbar punctures and myelograms. So a myelogram, essentially you do a lumbar puncture and then
Okay.
you inject contrast into the thecal sac around the spinal cord so that you can get contrast within the cerebrospinal fluid so you can image the spinal nerve roots and look for compression and those sorts of things. And I had so much fun. It's a relatively small procedure. You're taking a 22 gauge needle and advancing it into the thecal sac under live X-ray guidance. But I had so much fun. It was the first time I like looked forward to coming into work and couldn't wait to talk to the patients and do the procedure and that was kind of the first inkling I got that hey, there is an interventional side here. What let me explore this some more. And once I actually did my first interventional radiology rotation, so it was my first exposure, kind of like what you got. And I think my fate was sealed once that happened. I saw the
Absolutely.
range of
Fate
what
will
we
seal
work
that.
on. Yeah, and there was no looking back after that.
That's awesome. Did you have any it sounded like one of those uh it was you had one person who was an ortho resident and then you switched to what was it like a musculoskeletal vascular?
Yeah, it was a musculoskeletal radiology. So radiology actually has multiple subspecialties. So after you do radiology residency, you can choose to do a fellowship where you specialize in a branch of radiology, whether it's neuroradiology, for brain and spine imaging.
Okay.
There's musculoskeletal radiology for imaging joints, and there's abdominal imaging or body imaging, so that focuses on the visceral organs and the abdomen and pelvis. There's thoracic and cardiothoracic imaging, so people focus on imaging of the lungs and the heart. Just pediatric imaging which is its own specialty, and so there's nuclear medicine, which is a more functional method of imaging, and so a lot of different pathways to take within radiology that kind of let you specialize if you want to, or you could kind of be more of a general radiologist and kind of read a little bit of everything.
Yeah, absolutely. And it brings to mind like I did shadow a neuroradiologist before, and what was interesting was that they discussed like, oh, like they actually like sitting in that dark room, because and they actually like more so that intellectual conversation with like other physicians. But and I think like maybe you and I are kind of on the same page. Is like we want that like patient interaction because you know like you said don't want to be in a cubicle the entire time. But where I was getting at was that did you actually have any like mentors, any specific people like that resident that kind of guided you throughout your journey, so to speak, to where you are now that had a major impact on you?
Yeah, I think I kind of had two kind of groups of mentors. One was the interventional radiologists, here at UPMC when I was a resident were very supportive and kind of saw that I had a little bit of an interest, but had some questions and were really good about kind of taking me under their wing and kind of giving guidance. And it's funny when I was waffling, should I do IR? Should I not do IR? I enjoy it, but the lifestyle is a little bit harder than your average DR job. But I don't know if you would call him a mentor, but in a way he was. It was actually one of my co-chiefs, who
Oh,
was somebody who ended up being one of my co-chiefs later on in residency. Kind of looked at me and goes, "You're going to do IR." He saw, so he could tell. He would in hindsight he would listen to how I talked about DR and how I talked about IR, and it was very clear to him where I belonged.
mhm.
And that little push, I think, was part of what I needed. And that's his support along with kind of the other faculty around here who really wanted to kind of help me do well and kind of help me get to where I am.
I think it definitely sometimes takes like a mentor or just even someone like from like has like that third person perspective to kind of because it helps like you see someone like see something like objectively within a situation or at least like more objectively relative to yourself that you'd be like they can kind of point out like hey like you know you would actually be a very good fit for this you just
Yeah.
might not know it yet.
Yeah, exactly. Sometimes you just need an outside perspective to help you see something that's pretty clear.
Absolutely, absolutely. So actually, kind of shifting gears to interventional radiology itself. So actually, my first question about this is, I watched this video on YouTube, and it was by like this like medical influencer, it's like Dr. Lockham fucking or something like that. But in it, he talks about like how interventional radiology has like turf wars with like other surgeries or they're not even just surgery, just like other departments of medicine. Is that true?
I think a lot of areas of medicine, there's some element of turf battles. IR is definitely no stranger to that. There's an old joke in IR about how since the 1960s, we've been inventing procedures for other specialties to take. IR definitely has a bit of a history. We kind of pioneer a classic example is peripheral arterial disease. So working with in the arteries of the lower extremities,
Okay.
trying to help fix atherosclerosis and those sorts of things. That was kind of pioneered by interventional radiology. All the work in the aorta, endovascular stenting for abdominal aortic aneurysms, was all IR back in the day. And as time went on, vascular surgery slowly kind of took more and more of that, said, hey, well, we can learn how to do this. And so over time, there's been a bit of a shift in the specialty to where things that we used to exclusively do now at best are shared with other specialties, and at worst we are kind of having a battle a little bit. The arterial work in the extremities, some venous work, you kind of have to fight a little bit. Treating visceral aneurysms, we have to fight a little bit. Some places, I think there's really good collaboration with vascular surgery and with interventional radiology. Here in general, we get along with our vascular colleagues pretty well. But we also understand that peripheral arterial disease is pretty much gone from IR here and kind of sits in the vascular domain for now. And there are other places like Miami Vascular, where vascular is still, IR is pretty much the owner of all vascular disease. And so it does mean as a physician, as an IR doc, you have to work a little harder to build a practice. You go to, let's say you're a doc fresh out, and you set up a practice somewhere or you join an existing practice. Most surgeons, interventional specialties kind of own an organ system. And so, if I have a problem with the heart, I call a cardiologist or cardiothoracic surgeon. If I have a problem with the kidneys, and I need something done, I call the urologist. If it's a problem with your blood vessels, I'll call the vascular surgeon. IR, its strength is that we work on every part of the body, but it's one of the challenges is we don't own any part of the body, and so you have to work a little harder to build that referral base and to make those connections and to get those consults.
Interesting. I think that's actually a great opportunity. So, like, let's say if someone were to watch this podcast and they'd be like, "Hey, it's like, what is IR?" Because kind of like it seems like you guys have your hand in kind of everything because you're working on well, a lot of you're kind of like it's that crossover with vascular surgery. You kind of working on like arteries, like veins, like you're working almost like anything kind of that, and that touches a lot in the body. So if like someone who had no medical background, like and was to watch this, like how would you like in layman's terms kind of quantify or just like describe what IR is?
Yeah, no, that's a great question. It's something that I think we need to do better as a field in advertising. I think the way I kind of talk about interventional radiology is I kind of break the word apart. So we're interventionalists, so we use minimally invasive techniques that allow us to treat pretty much every part of the body using the real-time imaging of radiology. And so we really put those two worlds together. So rather than having to cut somebody open to get at an organ to treat it, because I can see into the body with X-ray and ultrasound and CT, sometimes even MRI, I can work through a pinhole incision and get directly to the organ of interest without having to cut somebody open.
It's like it's almost like it's like a step right behind minimal invasive surgery because
Right.
I've seen you guys operate and sometimes like the patient's still like they're still awake because you just have to numb an area.
Right. A lot of what we do is just under kind of moderate sedation or twilight sedation, as we call it, because a lot of what we do isn't directly painful within the body and we're working through pinhole incisions. After you numb the skin, they really don't feel a whole lot. I always tell patients there's no nerves inside arteries or veins, so you're not going to feel the work that we do within them. Now, there are some procedures that we do that are a little bit painful, so we typically use anesthesia. But part of what makes IR a lot of fun is pretty much every organ system, most places from the neck down.
Mm-hmm.
Although at some places, IR is involved in brain work and neurovascular work, but certainly everywhere from every organ system from the neck down, we work in.
Very cool. I mean, I hope you guys aren't showing them like the 12 gauge needle before it goes into them.
Right, exactly. No. We make sure that an
like,
old trick I learned from a mentor is don't let the patient see the needle. It looks scarier than it is.
like you squirt out the liquid just so like there's no air bubbles. Like this was it was just like
Yeah.
yeah, you know, I'm good. I'm good. I don't. It's okay. I chronic arthritis in my knees. It's fine.
Yeah,
We can
we're
go with
fine.
that.
No. We'll the best kept secret is don't let the patient see the needle and you'll be
That's
good.
great. That's awesome. Um, that's interesting. So also, I think what's really cool about you is that you have an interdisciplinary approach to medicine that not a lot of physicians have. So you have an engineering background. So you have your foot in one in that world, and then you also are a attending interventional radiologist. So you have your foot in this world, but it's actually through this 3D printing program that you're actually kind of weaving the two together. So could you tell me like talk about a little bit how you're using 3D printing in interventional radiology or just like in medicine in general? Like what have you guys been able
Sure.
to get done?
Yeah, no, I've been very, very lucky in being able to kind of start and grow the 3D printing program here at UPMC. Our goal is to use 3D printing to create, at its core, the bulk of what we do is creating patient-specific anatomic models for preoperative planning, surgical rehearsal. So if I can print out a model of somebody's arteries or their kidney and a kidney tumor, being able to hold that in your hand, get a true sense of what's going on, and actually be able to plan, or in some cases, even practice the procedure you're going to do, really helps make things faster, better, and safer. And so, I use it in my own practice from time to time. If I have a patient with a complex, say, a splenic artery aneurysm that needs to be treated, or they have a set of veins that are occluded, and I need to kind of recanalize those veins, having a sense of what the anatomy looks like.
What is so I mean for someone who watches like they're not going to know like what occluded. So like what does occluded mean? And like
Sure. I'm thinking of a patient who the vein that basically connects the vein that drains the right arm and the right side of the head before it connects to the heart, that vein was completely blocked
oh
by
okay.
the disease. And, there are a lot of different reasons those veins can get blocked. But once those veins are not able to carry blood, you kind of have to try to recreate that channel.
Okay.
And so we can use different sets of wires and catheters and work from within the blood vessel to basically bore through that blockage and use balloons and stents, which you can think of as kind of metal straws to help prop open those veins. And as you can imagine, if you're trying to recreate a channel from within and decide, I'm going to place a stent here. It's going to have this size.
Right.
Having a physical model can be pretty valuable in trying to decide what you're going to use and what tools you're going to use.
Yeah, absolutely.
The other area where this ends up being really helpful
Mhm.
is when I see patients in clinic. It's another area that we treat patients is with IR is treating cancer. And so one of the things we can do for a lot of tumors is do what's called percutaneous ablation, where using a CT or an ultrasound as guidance, you can place these needles into a tumor, and the tips of those needles either heat up the tumor and literally fry the tumor,
Oh wow.
or get very, very cold and freeze the tumor, and allow you through one or two or three pinhole incisions do the equivalent of cutting a tumor out, but without a big open surgery. And so having a model of that patient's kidney with the kidney tumor with me in clinic, I can say, hey, this is your kidney, this is a tumor, here's how we're going to approach it. The You see the light bulb go off in patients' eyes, where they truly get a sense of, oh, now I understand what's happening. Now I see why we're approaching it this way. And it gives them more comfort in the process, gives them, I think, better informed consent with what they're about to undergo.
Right.
And it gives them more confidence in the treating physician and the team.
Well, I can imagine like it's one thing to be told something, but it's another thing to be shown like, hey, this is how we're actually going to attack this problem. I'm curious, do you actually have a model with you or anything like that?
Yeah, so to give you an example of so here's one here. So this is actually, I don't know how this will project here. This is a model of the blood vessels and bile ducts within the liver.
Oh wow.
The blue here would be the hepatic veins. The purple would be the portal veins that drain the gut. The red here are the hepatic arteries, and the yellow are the bile ducts. These are the ducts that take the bile that your liver makes and brings it to the gut. And that is the size, shape, and scale of that patient's liver anatomy. And so
Like exactly.
exactly, we make it from CT scans, MRIs, even ultrasounds, and being able to, it's not just a generic model, it's not just a generic sketch, but it is that patient's actual anatomy. And it's a way for the treating physicians, the interventionalists, the surgeons to see what they're going to treat before they actually get in there and do the treatment.
It's interesting. I have a friend of mine who also does 3D printing. That kind of is a like it's a hobby, but also I'm pretty sure he also uses it in his work as well, and or starting to. And he talked to me how like a lot of 3D printers, from my understanding, they can like get pretty detailed as to like even down to like the texture of something. I'm curious like how detailed are your models? Like, I mean, obviously like two exact same dimensions, but
Sure.
is it depending upon like what you're trying to do? Do you get how like detailed you have to be?
Yeah, we picked the 3D printing technology that we use based on the application in mind. So based on the procedure that the surgeon is going to perform, based on the tools that we're creating, there's a wide range of 3D printing technologies, and we'll pick the one that kind of best solves the problem at hand. So we're not just simply printing on a model of anatomy, but we're designing tools to help make care better. And surprisingly enough, the limiting factor here is not actually the printers, but it's actually the patient imaging. So
Oh,
CT scans, for example, give us probably the best resolution of all of our imaging modalities for 3D type imaging. And the balance there is you can get better and better resolution, but you're limited by how much radiation you want to reasonably use on a patient. And so, today, practically the thinnest slice of a patient we can create with a CT scan is about zero point 0.5, 0.625 millimeters.
okay.
So that means that the best detail we can get of a scan is about double that.
Oh wow.
Now, 3D printers, on the other hand, rather than being limited to 0.5 millimeters, 0.625 millimeters, can actually have resolutions down to 0.025 millimeters. And so the printers, it's funny, 3D printers in the traditional engineering world are actually somewhat criticized because they're not as accurate as traditional machining. But compared to medicine, compared to imaging, they're way more accurate
Way
than
more accurate, yeah.
the imaging we can do. And so they serve our purposes just fine and
That's so
allow us to
interesting.
create that detail that we
So
need.
is it like the more radiation you use in your imaging, the worse the clarity of the image?
Other way around.
Other way
So
around.
you can, there's obviously a limit, but the more radiation you use, the better quality image you can get.
But conversely, the more radiation you use, the more potential harm to the patient.
Exactly. It's kind of like if you want to take if you want to take a picture of something that's moving very, very quickly, you want a very fast shutter speed.
Okay.
But the shorter your shutter speed, the less light comes into the camera. And so you need a brighter backlight or a brighter, light source to be able to still capture an image. And in radiology, it's the same thing. If I'm taking thinner and thinner slices, I need more. In this case, it's not visible light, it's X-ray.
Yeah, you up
So
the
the more
radiation
light you have
bit,
to
the better.
shine. Exactly. And
Okay.
so we have to strike that balance where we get high enough resolution and contrast to make a diagnosis, but not so high that we create harm. So the classic saying in radiology is it's you want your radiation dose to be as low as reasonably achievable.
Reasonably achievable. Like what? I'm curious. Just at what point does it become too harmful? Like I don't know what the.
The thing with radiation is it's there's no cutoff per se. There's certain dose amounts that we know cause harm. We know lots of radiation is bad,
Yeah.
and that's kind of all we really, really know. Everything else is a bit more complicated.
Okay.
And so that's why we don't necessarily have cutoffs per se. We just try to make things as low as we can make them while still solving the problem at hand.
You can't put on sunscreen to help.
Sunscreen does not help. No, no, that's been looked at, I think.
Gotcha, gotcha. No, no, that's really that's really interesting. So kind of going back to the 3D printing. So I'm curious, like, what's the process for getting a patient's treatment approved to use 3D printing, if that makes sense.
Sure.
Like, yeah,
We're pretty proud of what we've developed here. It's a pretty streamlined process. So if myself or one of the surgeons has a patient that they want to model for, they simply just reach out to us, and we take a look at the imaging, take a look at what they need, make sure that we can in fact create what they need us to create, and we get to work creating it. I think amongst the general public, UPMC kind of gets a knock for being a very um, finance driven system, but the truth of the reality is they are very patient centered and very forward thinking. UPMC looked at this and said, we can't make any money off of 3D printing, but it brings such incredible value to what we do. It makes surgeries faster, it makes them safer, it kind of puts us on the cutting edge of what we can do in medicine. We don't want money to be the barrier to getting this technology to our patients. And so for every 3D printed model we create for use in patient care, there's no charge to the physicians departments, there's no charge to the patients. UPMC actually absorbs the cost of that because they see and understand the value that this brings, and how life-changing the models can be, to borrow a phrase.
yeah, and I think you one time you said that what's the saying? If a picture is worth I saw this interview of yours. If the picture is worth 1,000 words, then the model is priceless. Could you unpack?
Yeah, that is something I do say. I always say that value there is you really can't put a price on it. Whether it's seeing the look in the mother's eyes of a young child who has a tumor that you're going to treat, to helping someone navigate their cancer diagnosis, or how you're playing a role in trying to literally put together the pieces after a trauma. It never gets old.
Absolutely. So can you walk me through like so your go for using 3D printing on this patient, or so do you then sit down with the surgeons? Like how does that work? Like you just sit down with the surgeons like, hey, like this is what's gonna happen, and then you walk me through the process.
Yeah, I think when someone first approaches us, or we first approach somebody about the value of could 3D printing play a role here, it starts with a conversation with the referring physician saying, hey, tell me about the patient. In a way, it's a clinical consult, just like any other consult in the hospital. They're consulting the 3D printing program to help out with the patient. So we chat about what's going on with the patient, what the disease is, and what the treatment plan is. And in some cases, it's a surgeon saying, I think I'm going to do X, but maybe I'm thinking about Y. And depending on the question they have or the plan that they're laying out, we design the model to help either answer a question they have or to help guide a problem they're trying to solve. So, if they're trying to decide, oh, can I do a minimally invasive approach to resect this tumor, or do I need to do a more open approach? We may print, the entire anatomy of that region. but let's say we're printing somebody has a heart defect and they're going to be doing a minimally invasive repair of some heart defect or some heart issue. We could just print a model of the heart as is, but then we can kind of take it one step further and say, you know what, I'm going to make this heart model come apart in pieces.
Oh,
And the way it's going to come apart is going to correspond to the same imaging planes on echocardiograms so that you can actually hold up the model and see the same image you would see in a cardiac echo, for example. Or, hey, we know you're going to be implanting this device and we know you've come at it from this angle. So I'm going to print you, have the model open up or be colored in a certain way that lets you see your trajectory more clearly. And so really it's not just printing out the anatomy as is, but it's truly creating a set of tools to help make that procedure faster, better, and safer.
yeah. So like, could you like print out like a heart and then actually you can literally, like you said, take apart the heart in a way that actually the surgeon actually might go in and do it?
Yeah, absolutely. Or, we can have it open up along the surgical windows that they're going to be creating in the actual patient. Or let's say they're resecting a tumor. We can actually make the tumor come apart separate from the model so they can visualize the hole that's left behind when the tumor is removed and kind of plan out, okay, well, how do I reconstruct the tissue in that hole? If I'm cutting out a piece of the mandible, I have to fill that with a piece of bone. Let me see what that defect looks like. Hey, why don't we create tools that will help me cut the bone I need to be able to reconstruct that part of the jaw? And so it's not just printing out anatomic models, but actually creating the tools to execute the plan we can then
Right.
create virtually. And so
So
it
speaking
never
of
gets old.
which, about the mandible part. So actually, and I'll actually maybe have to link this video in the description of the YouTube video of the YouTube video for this podcast. But there was actually a patient that they had a tumor on their, I forget their left or right mandible, but like that your lab was involved in treating that with that person, right? Could you talk me through kind of like that case, if you don't mind, if you're allowed to?
Yeah. This is you're talking about there's this article that we created as part of the UPMC Physician Journal, which
Yeah.
basically it was a short documentary form video that followed this patient who had this benign tumor on her jaw and was going to require pretty hefty resection of the jaw and reconstruction of the jaw after that tumor was resected. So we sat down with the surgeons and virtually performed that surgery with virtual 3D models and mapped out what the defect would look like and mapped out what they do is they take a piece of the fibula, which is a non-weight bearing bone in the lower leg,
Okay.
and use that to fill the gap. So we planned what that would look like and then design surgical guides. You can think of these as little stencils that fit onto the mandible and then fit onto the fibula with little slots for a saw that guide the surgeon on recreating the exact same cut that we planned virtually. And then there's a sister guide that goes on the fibula so that when you cut that little piece of bone out, it fits perfectly in the defect like a puzzle piece. In the old days, they would freehand all of this and try to make little connections and try to literally kind of square peg the round
Right.
hole. But now we can make everything kind of tailored to that patient. It doesn't get more patient-centered than that.
It sounds like it's going to be like a great game changer for patient centered care, if I'm reading it correctly, right?
It really is, and there's a lot of areas where 3D printing has become almost standard of care. We have certain surgeries with certain surgeons where the surgeon does not operate till they have one of our models in hand,
Oh wow.
and it's been kind of a humbling process to see this go from this crazy idea, this crazy thing I wanted to do when I was a bright-eyed, bushy-tailed resident back in more years ago than I care to admit, and uh, and seeing where it's grown and where we're at today. We have three full-time engineers. We produce hundreds of clinical models a year. We have three ISO 7 clean rooms that we manufacture devices that get sterilized. It's quite humbling to look at where we were and where we are and where we can go next.
I think it's also just to comment on like the this idea that I don't think this idea is necessarily widespread, but it maybe again it's like an irrational fear that if you're non-traditional, you're not going to be able to like as excel as much as you would if you went in the traditional route. But like clearly, like you're an example of someone who did not have a traditional path to medicine, and you have like achieved like monumental success. Like I can't think of many people that are able to blend like these two worlds together. One thing I want, so another thing I want to ask you is, since you're making guides, I'm assuming the actual material you're using doesn't really change that much. It's kind of like the same kind of like plastic or whatever you're using between
Yeah.
models.
So right now we're anything we're printing that would go into an OR, would be sterile, would touch a patient. It's a very small set of controlled materials that there's a whole range of testing that materials are required to undergo to prove they're biocompatible. And there's a whole set of requirements around making sure that the devices we make are, the raw materials biocompatible, and that the process we use to manufacture maintains the biocompatibility. And so all these materials have undergone lots and lots of very rigorous testing to ensure that they're safe, that they don't elicit any sort of inflammatory reaction, that you can indeed
Oh,
sterilize them.
but these things aren't going in the body. So, but they're even concerned about that. Like if there was like
So, well, the surgical tools that we create do touch the body, right? So these
oh,
surgical guides actually go in the sterile field, actually
oh,
touch
they
patients,
do.
actually contact the bone, and help you actually perform aspects of the surgery. So yeah, we are creating surgical tools that are used on patients in the OR.
So the reason why I wanted to ask you that is because, and I'm curious if this is a potential direction for the program. So I know, like in orthopedics, I'm sure you know that there's often like a lot of implants that are put into people's bodies, and like to like put like to keep bone together for like a certain amount of time, or even permanently, or even like sometimes people have like a traumatic leg injury and they have like one of those thick steel, or I don't know if it's steel, it's like titanium rods. I'm curious, is that a potential direction for the programs if you start printing those implants?
I think that is kind of one of the next things that we're eyeing. Now that we have these ISO 7 clean rooms, which are the same kinds of clean rooms that traditional medical device manufacturers have, we're starting to think about as the 3D printing technology matures, there are now technologies that will let us 3D print implant grade materials, PEEK being one of the plastics that's used quite a bit in the ortho world,
Okay.
bony world. And so we're starting to explore, what 3D printing technologies are out there and how can we bring this technology into the hospital and target cranioplasty plates for patients or custom fixation plates, as you were talking about for patients. Rather than forcing patient anatomy to fit an implant, why don't we just make the implant fit the patient?
Right.
And while traditional medical device manufacturing is very effective and we can create lots of tools, there's something about being at the point of care in the hospital. We can be nimble in a way that you can't be otherwise. We can create a medical device, an entire medical device for one patient, which the medical device industry traditionally may not be able to do because they have different constraints and different focuses. And so if there's this weird one-off case where they need a widget or a tool, we can design and make that tool. If an implant needs to be designed in such a way that is atypical from the usual implant size, shape, geometry, we can potentially do that one day. So I think that is why we're targeting certain types of implants. It's a long road between here and there. If the regulatory requirements and the infrastructure you need for a surgical tool is as high as it is, we've taken years to create. For an implant, it's even higher. You want to make sure all your T's are crossed and all your I's are dotted, so that the things you are making is safe and effective.
Yeah, I think actually we were talking before this. You're actually if you're a co-chair of like that regulatory or one of I'm assuming the regulatory bodies or something like that.
In a way. So, when there are new technologies that come to market, and physicians want to bring those new technologies into the hospital, most hospitals have some sort of process by which these requests for new devices are reviewed, vetted, and approved. And
Okay.
so you don't want it to be the Wild West where everyone's just bringing in different things.
Yeah.
You do want some sort of process so that the claims the companies make can be kind of vetted
Mm.
and look at the not only the efficacy of a device. Hey, is this thing actually going to work the way they say it is? But is it going to be safe for our patients? Is it going to be financially viable for the hospital? Right? Is this something the hospital can afford to do? And all that has to be kind of looked at and evaluated. Most hospitals call it a value analysis team, a value analysis committee, and I am part of that process to make sure that we are being very cautious and circumspect with what we bring into the hospital, but also wanting to stay at the forefront. It's a very tricky balance to strike sometimes.
Not that we want to throw out names, but I'm curious. Has anyone brought anything before you guys and you just kind of like all looked at each other and like this isn't this isn't gonna work, buddy. Like, what are you doing?
You do get a range, you get some things that are submitted. There's a lot of a company, or there's two or three companies that have a device that does one thing, and another company comes along that's essentially the same thing, with some small difference. You're like, well, we already have three different tools that do this. Why do we need a fourth?
Yeah, right.
Or,
All right.
hey, this technology, okay, sounds very different, but it has no research behind it. Or, hey, it's got very little, data to support what they're claiming. And so a lot of times we say, you know what, this is very interesting, but before we really want to use it on our patients, we want to know that it's truly is. We need more data. We need more study.
Mhm.
Hey, how about you go off and do a clinical trial, or help gather some data, and we can prove this out a little bit more before we start using this wide scale. So that's, in a way, that committee is a steward, who works to make sure that we're only using the tools that are proven and safe.
Very cool. I'm curious. So I know, like I think SpaceX actually has a lot of those rockets actually have like 3D printed like titanium like plates or shielding on them. I'm curious, like, do you think you'll we were going off this like question, there's this thread. Um, do you have the infrastructure to print like metal, or is that something you guys have to get?
Sure. So today we don't 3D print metal, here at UPMC. There are a couple places that do use metal 3D printing. Right now, I think to do 3D printing at scale, and traditionally these printers are big, they're expensive,
Mhm.
and they're a little tricky to run. And so it makes it not quite practical for use within the hospital. That being said, one of the exciting things about the 3D printing world is that the technology is changing at such a fast pace. I mean, just a couple of years ago, we in the last 2 years we've had such big shifts in the technology available and how the technology works. We are, I think, on the precipice of some big changes with metal 3D printing that will make it practical and make it so that we can do it, cheaply, with a high enough quality at the point of care. So I guess the short version is we don't 3D print metal today, but I think shortly tomorrow we'll hopefully be able to do that.
I do think it's crazy. You think about like the trajectory of just technology in general. Like it's, I mean, we have like the AI boom and stuff like that. So you have, it's just exponential increase. I'm actually curious. Do you use AI in your 3D printing?
So in the 3D printing right now, we don't. I think AI is still in its early phases when it comes to 3D printing. There are some areas where people look at it, whether it's preparing things for printing or actually monitoring the printing process. But right now, it's a little too early in its infancy, in my opinion. Where people are exploring AI the most is probably the most cumbersome and expensive and difficult part of the process of taking a CT scan or an MRI and turning it into a 3D printed model. Is that process of taking those individual 2D slices and turning them into a virtual 3D model. That process is called segmentation. And it can take anywhere from, take a person anywhere from 5 minutes to 3 or 4 hours, depending on the complexity. And AIs have come a long ways in helping with that process, but still have a long ways to go, in my opinion. So very interesting. And I think, where AI is being brought into the clinical medicine is pretty interesting,
Mhm.
but time will tell.
Do you? Oh, so I was reading this book called "Cells Are the New Cure." I think it's by Dr. Robin L. Smith and Dr. Max Gomez. I'm sorry, not Gomez. But they talk about this technology, this concept of you're actually printing like tissue, like
Mhm.
actual human tissue. I think they had like one patient that had like esophageal cancer, and they basically took out a piece of his neck, and then they just printed like basically the scaffold for that hole in his neck to like grow back. Is that also something that you guys are looking into? Potentially might be a thing in the future.
That is very much the forefront of the field, bioprinting, and I think you hit the nail on the head. Initially, there's a lot of interest in 3D printing actual cells, but there's been more and more interest on printing the scaffolding, because what the field is finding, and then this is by no means my area of expertise, but if you create scaffolding for the body and give it the right kind of growth environment, your cells can kind of reconstruct anatomy. And so, the right scaffolding with the right mix of growth factors, and you can grow a new biliary tree. Or the right scaffolding and the right set of cells, you can grow new heart muscle, for example. And so, I think in our lifetimes, we're still quite a ways away from 3D printed organs. There's been a lot of very interesting work in 3D printing kidneys and livers, heart tissue, even ovaries, for example.
Wow.
And while complex organs like the kidney and the liver, I think, are a little ways away, we're seeing more and more exciting developments with smaller goals. 3D printing a bit of heart tissue to replace damaged heart tissue from a heart attack, or 3D printing ovarian tissue to replace tissue that a young woman may have lost because of cancer.
Yeah.
So it's pretty amazing the advances that have come out of that field, and I'm very excited to see where it goes next.
No, I'm sure. I imagine like if someone had to get like a mastectomy, but you're able to 3D print like basically like breast tissue back or something like that. I assume like a lot of women would love that. And then actually ovaries, like people who have to take out the fallopian tubes and stuff like that. Yeah, no, that'd be a game changer for sure. Um, One thing I did want to ask you is kind of shifting to uh just a bit of personal life, just because Dr. Ghodadra, you wear like so many hats. You're an interventional radiologist. You're a director of a 3D printing program. And then when we're trying to set up time for this podcast, I was like, "Hey, can we do the weekends?" He's like, "Dude, I got you're a 4 year old. You got a 4 year old. I can't do this." So no worries. But I'm like, man, this guy's a doctor. He's an engineer. He's a director of this program. He's a husband. He's a father. How the heck do you find time to do all this? Is there a
It
secret?
is. It is. I don't sleep as much as I wish I could. I think it is. That balance is it's a constant battle, and I think it's important to think about when you're thinking about the job, the specialty. That home life is important, right? You cannot be working constantly. You cannot. Um, your life can't be at the hospital. You need to have a life outside of that. Unfortunately, I think what we've seen, I'm what you'd call it, a geriatric millennial. But what we've seen in the millennial generation and even in Gen Z is the recognition that, okay, work is important, and especially in the medical field, the work we do is reaches a lot of people, but you have to have that work-life balance, and it can be hard sometimes. I think with 3D printing, for IR, we have emergent cases and I'm on call. We come in the middle of the night for stuff. For 3D printing, there's emergent surgeries. And so my engineers take call, for example, and they're coming in on nights and weekends to get models ready in time for rapid fire surgeries. And it can be tough. You miss swimming practice and baseball games. And you have to make an effort to say, look, I'm going to draw a line here and I'm going home. I'm turning off my email.
Yeah.
I'm on vacation. I'm going to travel. I used to have this really bad habit of coming into work when I was on PTO. And you can do that maybe early in your career, but as you move through your career, you got to strike that balance. You want to see your kids grow up. You want to see your significant other
Yeah, absolutely.
and enjoy those aspects of things because if nothing else, this job gives you perspective. You see what so many patients struggle with and the challenges they have. It should make you grateful for where you are and being able to kind of be able to spend that time.
What's been like your secret to like uh managing that time? Is it just or even not even necessarily managing the time, actually it's just having those having that time away from the hospital that kind of recharges you so you come back to work like
Yeah.
refreshed and ready to
You,
go.
if I figure out that secret, I'll let you know. I'm still searching for that answer myself, but to the degree that I can, I try to, when I'm not on call and I'm not at work, you put away the phone, turn off the email notifications and just be with your family. And even if you're just, doing silly things, taking a walk, I try to, even something as silly as like taking the dog for a walk with the little one. Even those 15 minutes can be recharging in a way. And unless you make the concerted effort to do those little things, it we're all exhausted when we come home from work, and it's easy to say, look, son, I'm tired. Daddy's gotta relax. It's like, no, you're in 10, 20 years, you're not going to look back and be like, oh, I'm glad I took that nap. It'll be, I'm glad I spent time with my kid, even though I
Yeah.
was exhausted.
Yeah, I mean, that's honestly really like it warms my heart to hear that. I was afraid you like 3D printed like a life size model of yourself and you just stuck it in your house.
That may be a good backup plan. I may look into that. It's
Dad,
Yeah.
Dad's not. His lips aren't moving. What's wrong?
But it's no, it's yeah, it's very easy to get sucked in. But
His
you know
smile looks
what? In
plastic.
a way, it recharges you. Like there is nothing better than getting home and having the kid excited to see you. And uh, you know, I brought him through the 3D print lab a little while back and showing him, getting him excited about some of the stuff that we do. And but yeah, I try to get outside as much as I can. As you know, in Pittsburgh, the sunny days are few and far between, and so try to enjoy
Yeah,
them when I can. Try to have hobbies outside of the hospital. We're always chasing that work-life balance.
absolutely, absolutely. Actually, I'm curious. Like, I know physician burnout has been a something. It's been something we've been paying a lot more closer attention to
Yeah.
nowadays. Do you think, uh, in your opinion, do you think we're seeing a lot more of it because we're catching it more, or because there's actually something systemic within this hospital system? The hospital medicine isn't perfect, so like, is it something systemic within the hospital system that is aggravating this, or what's your thoughts?
Yeah, no, I think it's a bit of both. I think the environment has gotten, especially in the post-COVID world, right? Everyone is short-staffed, everyone is overworked, everyone has fewer resources for more work, and it is very easy for that burnout to manifest. And in the past, I think it was, look, just kind of buck up and power through, and it's why you see things like rates of depression and suicide and alcoholism and drug abuse being higher and higher in the physician community. But now that there is more recognition of that, more attention paid to burnout. I mean, we do these annual surveys at UPMC on employee satisfaction, those sorts of things. They screen for burnout as part of that, and it's done in a way that's not, it's not retaliatory or anything like that. It's like, hey, are you burnt out? Well, hey, here's some resources for you.
Right.
The UPMC has a lot more resources now for physicians and their families on dealing with burnout and helping to strike that work-life balance. And we since we are paying attention to it more than we used to, we are recognizing just how widespread it is. I mean, everybody suffers from burnout in some way, shape, or form. And if we don't talk about it, we don't look for it and plan for it, then we'll never be able to address it.
If we were to, so if I could snap my fingers and kind of put you in charge for like the mental health of doctors for like a day, what would you say would be like one measure you would implement to like kind of would help alleviate some of this?
That's tough. I think with the magic wand, it would be, more resources, more staff, that would allow more time off and, an easier time working through just the immense workload that everybody has. But in the absence of a magic wand, I think it's bolstering these programs that exist for staff or physicians. It's not just a pizza party for overworked staff, but it's we moving beyond the cliche pizza party and moving towards actual resources to alleviate work-life balance issues, alleviate childcare issues. We're seeing more and more childcare options, within the hospital or around the hospital, things like that. I think will go a long ways to helping to mitigate some of those struggles that we all face.
Yeah, absolutely. I think it's obviously this would be a long ways out for me, but it is something that I think about like uh, if I'm able to manage my time effectively when I am in an attending physician, and because I do want to see my kids eventually. Like I want to have kids. And, my dad was able to do it. Well, in his early stages of his career, he was kind of traveling all over the place, so we didn't see him like too often. But I was also young, so like I didn't remember. But then like nowadays, like he's able to work from home and stuff like that. So it's a little different. But my point being is that like I think about like okay, like what do you actually start to value when you get older? And it's like that. Do you do like to your point? Do I value that nap that I took, or that promotion in my job? And the promotions can be like gratifying, I'm sure, but
Mhm.
it's when you look back on the course of your life, it's like as a physician, I'm sure it's like how many people you've helped, and then it's like in your personal life, it's like was I a good dad to my kids, like do I
Mhm.
have a good relationship with my family? I think would you agree? Would anything?
Yeah, no, I think that's fair. I think it's always kind of keeping in the back of your mind what how important is this? One of the things I always like to kind of remind myself is kind of what I call the 6 week test, which is if you're finding yourself worked up about something or stressing about something or trying to decide on something, think about, okay, flash forward 6 weeks. Is the thing you're worrying about now going to be a problem in 6 weeks? And will you still be worried? Will it still be impactful in 6 weeks? And if the answer is no, then maybe we let that go and we don't stress about it. And it gives you some perspective on what's worth worrying about now, what's worth focusing on now, and what's maybe worth worrying about later.
Yeah, a great book on that actually, by the way, is it's The Subtle Art of Not Giving a, I'm not gonna curse, like F word, on, by Mark Manson. He talks about the concept of how, like, you can actually you can choose what to care, you can choose what to care about, you can choose what to give an F about, right? But by doing that, by prioritizing what you actually care about, it actually, like, it alleviates the mental burden of, like, worrying about all these other things, and that it's often like the first step to kind of de-stressing, so to speak. You're just getting rid of that excess stress that you don't actually need.
Yeah, that
No,
makes a lot
that's
of sense.
great. I think it would be a good way to leave off the podcast. If you had to, if you had to tell your younger self, like, think, Dr. like Ghodadra, Anish, at like 20 years old, 24 years old, however, like, it's just in his 20s. What would be the advice that you wish you received about, like, it could be life, it could be about being a physician?
Sure. I would probably say, first get a better haircut. My 24-year-old self. No,
The sideburns, you gotta get the
yeah,
sideburns.
yeah. I know. I think, honestly, I think I would tell myself a lot of what we've been talking about in the last little bit here is, hey, don't sweat the little things, and just keep true to yourself and keep plowing ahead. And there's this old Douglas Adams quote about how I may not have gone where I intended to go, but I ended up where I intended to be. And I think that very much applies when I look back on kind of where I thought I was going to go. I thought I was going to end up as a device engineer only. I thought I was going to be an orthopedic surgeon. I thought I was going to be a diagnostic radiologist, and I thought I was going to do only IR, and to kind of take a step back and see where I'm at now. I did always have this dream of living in both worlds, the engineering world and the world of medicine. And you know, if I had a nickel for every time someone told me, look, that's cute, but no. I could fill up jars. And so I would say continue to be persistent, maybe even annoyingly so. And there's no barrier you can't break down without just slow, constant pressure. Just keep chugging away, keep plugging away, and you can build great things.
I can't think of a better way to leave off the podcast. Dr. Ghodadra, thank you so much for taking the time to do this. I know you're a busy, very busy man, with a very hectic schedule. Even warned me before this. You're like, hey, like, I just might get called in the middle of this, so just
Sure.
keep in mind. Is there any, like, social media? Like, usually, typically in podcasts, just ask if there's any social media that they would like to plug. I know, unless you are on Instagram, but do you have, like, any LinkedIn or anything like that you want to plug?
I do have a Twitter handle. I really don't post as often as I should. A Gododra MD. Every now and then I'll post a 3D printed model picture or something like that. And you can learn more about the UPMC 3D printing program at upmc.com/3D printing to learn a little bit more about what we do. But no, I appreciate the time, and it was a lot of fun.
Yeah, this is a great time, man. I can't wait to do this again. We might have to have you on again at some point. That can catch up. Maybe when you get the 3D organs, like the organ startup, or the implants. I think that'd be a cool check in.
There you go. Absolutely looking forward to next time.
All right, thank you, Dr. Ghodadra.
Yep, thank you.